Okay, guys, I am skipping over quite a bit to start off part three. I'm basically skipping over the primary assessment, the history taking, and the reassessment of your patient. You guys can read over that during your own time, okay? I want to get into the actual emergency care for the diabetic patients, okay? And unfortunately, for the basic level, the only thing that you guys to have to try to combat this is oral glucose. And the thing with the actual oral glucose is remember that it's actually a buccal. Even though it's called oral glucose, it's actually a buccal administration. Make sure you guys are looking in your lab shelves to find the actual videos on how to administer a medication buccally. There are three different types of actual oral glucose. It either comes in a gel, a tablet, or a liquid. The picture of the glucose that you guys see on the screen there is the more common ones that you guys are going to see in our system. It comes in a lemon or a grape flavor. They don't taste like that, though, that's for sure. If you guys ever get a chance to taste this, go ahead and do it. It's not the most pleasant stuff on the face of the planet, but it'll raise your sugar levels for you, and that's all we care about, okay? So we're going to talk a little bit more about actually giving this, and we need to kind of make sure that you guys are going over your pharmacology lecture for specifically oral glucose before you guys go into this exam, and I'm going to hit on just a couple points here in a sec. So this is a very big contraindication for you guys. The inability to swallow or unconscious. Well, unfortunately, when we get called for 911, by the time that we do show up on scene, these people are pretty damn close of being having the inability to swallow or unconscious. Okay, this is a big reason why a lot of the higher levels of licensure, specifically the intermediates and paramedics, and to be honest with you, a lot of nurses are really trying to push for our basics here in the state to be able to administer IVs because really that is the most preferred way of delivering glucose to our patients. Because you guys, as basics, if you show up on scene and that family decided to call a little too late, you guys are already on scene and it's already game over for you guys. You have to call an ILS or an ALS unit there in order to start that IV and for us to start feeding them sugar through their veins. Okay, so that's why we give you guys the opportunity to make this a buccal administration. And buccal is basically where you're putting this stuff in between the actual cheek and the gum line, and we're hoping that this actually absorbs through the mucosa of the mouth. If they are unconscious, now don't put a lot in there because remember they're not able to swallow this stuff. We don't want to cause an airway obstruction. So make sure that you guys are using a tongue depressor in order to use the buccal, but make sure you guys are also watching that video in your lab shell on the buccal administration so that you guys can actually see how it's done. Moving into the actual presentation of a hypoglycemic patient. If your patient is seizing, this should be considered a very serious seizure, specifically at the basic level, because I don't care what you have in your arsenal, which really isn't anything. You're not going to be able to stop this seizure. And if you guys call for an ALS, ILS intercept, the only thing that's going to stop this seizure is sugar. Okay, so hopefully, you guys have already done some history taking with somebody that's on scene that possibly knows this patient. Remember that we're also looking for medical ID bracelets. We're looking at smartphone apps that are out there and available in order to see if we can find information on this patient, right? But every seizure medication every quote unquote seizure medication that I carry as a paramedic is not going to stop this seizure until this patient gets some sugar. So again, hopefully before I arrive, you guys have a baseline set of vitals for me in order for me to help actually treat the patient as soon as we start getting on scene. Possible causes, again, for the hypoglycemic. Um, Infections, okay, specifically for our diabetic patients. Possible poisonings, maybe if somebody doesn't really have a history of diabetes and for whatever reason they're hypoglycemic, could be a poisoning. It could just be hypoglycemia, guys. It could just be that this patient just needs some sugar, okay? Traumatic events can cause hypoglycemic in some patients, decreased level of oxygen. Sometimes it's idiopathic. We don't know why. For whatever reason, somebody just had a hypoglycemic episode, and fevers and undiagnosed epilepsy in children can be caused hypoglycemic or can be caused by hypoglycemia. That's why when I was talking to you guys about the seizure lecture in neuro, anytime that somebody has or is seizing, let's make sure that we try to get a sugar on them if we are able to without actually hurting the patient. And specifically, once that seizure stops, if we have a known epileptic or somebody that we know has seizures, let's make sure that we get a sugar level on them because they had just burned a metric shit ton of energy. And we need to make sure that they have enough energy so that they don't slip back into a seizure. Okay, so we're going to stick on seizures here for a little bit, okay? Obviously, any seizure will indicate possibly some other kind of underlying condition. We need to make sure that we are doing our best to secure that patent airway for our seizing patient. That's easier said than done sometimes, guys. We want to try to place the patient on their side, pretty much like the left or right lateral recumbents. But if the patient is seizing, we don't want to hurt them while doing this. Don't fight the seizure activity in order to place them on their side. But definitely have your suction supplies ready just in case. And we want to make sure that we are providing oxygen, whether if we can get the actual like a nasal cannula or a non-rebreather onto their face. If not, let's just do a little blow-by oxygen where we're going to take that non-rebreather. We're still going to fill up that oxygen bag, and we're going to hold it as close to their face as possible so that when they do start breathing, at least they're getting oxygen in, okay, and transport promptly. The other thing I do want to say about seizures with hypoglycemics is there could be a possibility that they are still breathing during the seizure. This is kind of the anomaly of the actual hypoglycemic patient. Most patients that have seizures are not necessarily breathing during the seizure. A hypoglycemic can be breathing during the seizure, so we can try to put oxygen on these patients if we know they are a hypoglycemic. When you guys are dealing with somebody with altered mental status. Here's the big part about the whole thing. The hypoglycemic patient can appear to be intoxicated. A diabetic patient that is actually being confined by the police is at a very, very high risk of not being treated accordingly, right? So we need to make sure, and this is why we are called out for all basically altermentations and all intoxicated males or females or whoever our patient is, in order to make sure that they are just intoxicated and it doesn't happen to be a diabetic problem, okay? Please make sure you guys are keeping a lookout for medical identifications. Make sure that we're performing a blood glucose test at the scene. And diabetics and alcoholics can coexist in a patient. Okay, they can be alcoholics and a diabetic, so keep that in mind when you guys are going out there. It might not just be the quote unquote another intoxicated patient. They could be both intoxicated and also have hypoglycemia. So hypoglycemic, anytime that we have somebody with an altered mental status, they technically cannot support their own airway. So the tongue is a problem. The possibility of them vomiting is a problem. We need to make sure that we are carefully monitoring that airway. We want to make sure that we're placing the patient in the right or left lateral recumbent position, depending on where we are at. And always, always, always make sure that suction is available for your patient. Guys, that's it. That's going to wrap up our endocrine emergencies. Please make sure that you guys are looking over the primary, secondary, and reassessment slides that I missed or that I skipped. If you guys have any questions, please feel free to email me. You guys know how to get a hold of me, and I will see you guys in our next lecture. Thanks a lot, guys. Enjoy.